a maternal death is a tragedy. Each maternal death is a sentinel health event for which the occurrence of a single case justifies asking, why did it happen? A good day to all of you. Today I'm going to talk to you on learning from maternal deaths to improve the outcomes of pregnant women complicated with heart diseases in low and middle income country settings. Sri Lanka is located in the Southeast Asia with a population of 22 million, and our general literacy and female literacy are very high. We have a live birth cohort of nearly 275,000 every year. This is our national maternal death surveillance and response system, which was established far back in 1959 and continued strongly throughout the history. When there is a probable maternal death from both field sector and also from the hospital sector, is generated a review process. The first step is a notification sent to Family Health Bureau, Ministry of Health, and from the hospital also we get a notification. Then at both levels they do a structured review of the case by visiting the household and also at the ward. Then the compiled data are sent to Ministry of Health, where we process these data and compile case scenarios, and they are subjected to a desk review at national level. Then we go back to the district level, discuss these cases, and come up with recommendations to further improve maternal care and prevent maternal deaths in the country. So in conducting postmortems, it's a mandatory for all the probable maternal deaths in Sri Lanka. You see the coverage, it nearly 99%. This means that we will get a valid cause of death for each and every maternal death, but at the end, the final determination of the cause of death is done by an expert group reaching a consensus. So these compiled case scenarios we review with experts from a multitude of experts, including obstetricians, cardiologists, anesthesiologists, physicians, public health specialists, and we jot down issues with regard to each and every case. And then we come up with recommendations to address these gaps if there are any. So we review these deaths on a 3 delay model, whether there is a delay in seeking, reaching, or treating, and in an environment with a no fault finding. And there are no names, no blames, and we keep it to confidential. This is how Sri Lanka's maternal mortality ratio dropped down from 1911 to 1995, and it further went down to 29.5 per 100,000 live births in the year 2020. So in this study, we took 2,657 maternal deaths which occurred from 2001 to 2020, to nearly 20 years, and we identified 383 maternal deaths with heart disease as a cause. So you see the progression of total number of maternal deaths and the static nature of the number of heart disease. So it's basically fluctuating between 10 and 35 more or less number wise in a static level. So over the years, heart disease is contributing as a leading cause of maternal mortality in Sri Lanka. You see in 2015 it was the number one cause, 2016 number 2, and 2017 also number 2 with 20 deaths, and in 2018 it was the third leading cause, and in 2019 again it came the leading cause of maternal mortality, and lastly in 2020 it assumed again the leading cause of maternal mortality on par with obstetric hemorrhage. So is a significant cause of maternal mortality in Sri Lanka. You see over the years how the direct causes of maternal deaths uh, reduce in the country, especially hypertensive disorders, obstetric hemorrhage, amniotic fluid embolism, and all other direct causes. But heart disease, the cause-specific maternal mortality ratio is fluctuating. But again, over the last 3-4 years, we see a reduction in the indirect causes of maternal mortality and the relative place of heart disease in this regard. So in this analysis, we saw a disparity in ethnic groups, especially Sri Lanka. Majority population is Sinhalese. So in line with that, 63% of these deaths were in Sinhalese, and Tamils 23% and Muslims 40%. But this is we see that relatively high proportion of maternal mortality due to heart disease is seen among Tamils and Muslims. So age of the mother, so you see the age range, the 16 to 49 years. You see the 21% of women are from 36 years to 40 years. Sorry, 49 years. And the parity wise, the primaries are the number one, 37%. Over the years, you see the relative contribution of different parities to maternal mortality due to heart disease. Um, when we look at the category of heart disease, rheumatic valvular heart disease contributes with 37%, and congenital heart disease 25%, cardiomyopathies 12%, and primary pulmonary hypertension 6%, and all other groups you see the relative contribution. So when we look at the congenital heart disease, many are due to atrial septal or ventricular septal defects is nearly 40%, and rheumatic valvular majority more than 50% are mitral stenosis. When you look at the district occurrence of maternal mortality due to heart disease, you see there is a wide disparity in occurrence of these deaths in pregnant women. And it's a significant variation we see in congenital heart disease. The majority of them are seen in so-called more developed districts, and less so-called less developed districts contributes only 38% to congenital heart disease. And remarkably, rheumatic valvular heart disease is seen in so-called less developed districts, contributing with 58%. So it is more less seen in so-called developed districts. And when you look at the timing of deaths, many of these women died after either delivery or abortion. It contributes 59%. And uh, with regard to place of death, the 66% of these women died at specialized unit. That means many of these women had time to visit a hospital, and then have sort of services, care services, and later only they died. But you see at home or on admission to hospital, there is a significantly 11% of women died without receiving care. Is the further details, you see 29 cases died at home. What went wrong? this is what we do at the maternal death reviews. We go into deeper and deeper to find out the things went wrong and whether we can do some remedial actions. So there were uh, previously many women, they have been advised not to get pregnant. Those are medically contraindicated pregnancies, but they conceived despite medical advice, and there were 54 such women over the last 20 years who conceived and then died. Unmet need of family planning. Many of nearly 38%, that is 146 women, could have been saved had they been given proper contraceptives by the field service providers. So what we did out of these lessons learned, we translated this into action at different levels. So we prepared minutes of all these death reviews and distributed they among all the possible stakeholders, maybe policy makers, health administrators, professional colleges, clinicians, medical students, postgraduate trainees, and field healthcare givers. So with that, so what we wanted is action. So we went to media to educate general public. Then we educated stakeholders. We shared these outcomes with them, and we sent circulars, guidelines from the Ministry of Health, and we got down experts, especially from this Dr. Uriel Khaim from USA, who came to Sri Lanka and transferred USA care delivery patterns to our clinicians in a series of workshops with regard to further improve maternal care in Sri Lanka. So we saw that many women are endangered. So we started a red book to register eligible women in danger, and we gave them targeted care. So media awareness is very important, general public. So we went into media and educated general public. And we started multidisciplinary approach. So we started from antenatal clinics where, in the very first time when we capture a woman with heart disease. So she is given multidisciplinary antenatal care, and also when they are admitted is again the multidisciplinary care. If it is critically ill pregnant women, the caregivers should be physically present to make a decision with regard to her care arrangement. So all in all, this is what we do in Sri Lanka. So we have done numerous actions based on the maternal mortality due to heart disease, and we translated lessons learned into action. So if we think different, do different, we can change the system. Thank you very much for your patient hearing. Thank you.